Our institutional experience with robotic major hepatectomy, does time improve outcomes? I am Dr. Iswanta Sukandi, an HPP surgeon working in Tampa, Florida. This is our HPP team in Florida. I do not have any disclosure pertinent to this presentation. The purpose of this study was to analyze our institutional outcome for robotic major hepatectomy. The hypothesis is major hepatectomy has a learning curve. It has been published in multiple journals, and there are differences in terms of how many cases that you need to be proficient for a minimally invasive major hepatectomy. We know that as surgeons gain more experience, the outcome is expected to improve, and along with the better outcome, surgeon is more comfortable as well to do a more complex cases. And we will see with our experience here that all of those are true. With IRB approval, we followed our 371 patients who underwent hepatectomy from 2013 to 2020. For the reason of this specific study, we analyzed 144 patients who underwent robotic major hepatectomy, and they were simply divided into two groups. The first group contained 72 patients, and the latter group contained also 72 patients. We excluded patients with a minor hepatectomy, and the major hepatectomy is defined as a resection of 3 or more Cunard segment. Operation were assigned a Iwata score to analyze the difficulty of the operation in an objective manner. We perform a regression analysis, t-test, and Fisher exact test to compare those groups. And data are presented as a median plus minus mean standard deviation. This is an OR setup for our robotic major hepatectomy. We utilize dual consult for the purpose of teaching the fellow. The bedside surgeon is on the right side of the patient, the scrub takes on the left, and the robotic system is docked from the patient's right shoulder. This is our port positioning in general for right and left hepatectomy. We utilize 5 ports. And this is an overview of Iwata criteria, which everyone is quite familiar with. And this is a demographic of the patient. The first 72 patient and the last 72 patient, and age, sex, BMI, lesion size, MELD score, child PU, and ASA class are pretty much comparable. However, the Iwata score for the first 72 patients, the median Iwata score is 8, and that score increases to 9 as we gain more experience, since we are more comfortable undertaking a more difficult, more complex robotic major hepatectomy. And the difference in Iwata actually reach statistical significance. This is a graph that analyzed the Iwata score. You can see here the average Iwata score is 9 on the second group. You can see the line is actually going up as we gain more experience with time. This is the intraoperative result of those two groups. The operative duration actually increased, and we explain this as a surrogate marker of case complexity. The operation is a bit more time consuming because they are more difficult to do as we gain more experience. The estimated blood loss, however, stay the same even with more difficult cases, and our R0 margins also stay the same. And you can see here a 61 patient in the first group had R0 resection, 5 patients with R1 resection, and this is mostly R1 vascular. And in the last group, 61% had R0 and 2% had R1 vascular. And the intraoperative complication, we had one patient that had major hemorrhage during the operation from major hepatic vein bleeding, and we had to convert the patient emergently for an open laparotomy, and we counted this intraoperative complication, and this is something with our learning curve, and we quickly learned from the mistake. We did not have any issues with handling a major hepatic vein on the second part of the learning curve. At the beginning of the experience, we admit a lot more patients to the ICU. This is probably more from the concern of not knowing how they do after robotic major hepatectomy. So we have a low threshold of admitting them to the ICU. In the later part of the experience, we are quite confident they do not need to go to the ICU. Therefore, we only place a patient who are really having any hemodynamic concern during the operation. And out of 72 patients, only one patient who need to go to the ICU in the second part of the learning curve. Post-operative complication stay the same, 4 out of 72 patients. We can see the clavia dindo class is about the same. Length of stay is about the same, 4 days for a major hepatectomy. We had one patient who died in the hospital on the second group, and the readmission rate stayed the same, about 13 to 15%. This is a graph of ICU admission. As I mentioned earlier, we utilize ICU less and less. Majority of patients after robotic major hepatectomy, even extended right hepatectomy, they do not need to go to the ICU. And this is a regression analysis of the ASA class. We utilize this as a surrogate marker of the sickness of the patient. And we are also undertaking operation robotic major hepatectomy in the sicker and sicker patient. They all have preoperative comorbidities. However, we're more comfortable on doing a major resection, even though the SA class is higher. This is the operative duration. Unfortunately, operative duration increased with the experience, and we all think that as we more vessels with the robot and more vessels with the major hepatectomy, the operation should get shorter. Actually, it goes the other way, and I attribute this as a surrogate marker for case complexity and comfort level of doing those complex operations robotically. Conclusion, our experience with robotic major hepatectomy showed more difficult major hepatectomy were undertaken, a higher EWATA score, perioperative complications were kept at minimum, ICU admission significantly decreased, however, operative duration increased. As I mentioned earlier, regression analysis shows a significant decrease in ICU admission, increased ASS score, and increased operative duration as a surrogate marker for case complexity. This is our experience with the robotic major hepatectomy from Advent Health in Tampa. Thank you very much.